Am I
Yeah.
visible and
Yes, now
audible?
audible. Now audible.
Yeah.
Wonderful, wonderful, wonderful. So we have both the speakers here, and I think we are so much indeed fortunate. I still, because I've joined just right now, may I ask the organizers, the president, Dr. Ravinder Gera, and Dr. Bhushan Patil, have they made the initial introductions? Then I can
Yeah.
start.
Yeah, because Dr. Dinesh had joined few minutes back, so
Okay.
we have kind of formally welcomed him. Now I can see Dr. Gandhi is also there online. Sir, good
Hello.
evening. Good
Wonderful.
evening, sir.
Hello.
Good
Good
evening.
evening.
Good evening.
Hello. Yeah.
Yeah. Thank you so much,
Wonderful.
sir, for consenting to present in on our forum. I am Dr. Bhushan Patil. I am the secretary of the organization HAOI Haryana, who is conducting this webinar. Dr. Ravinder Gera is the president, and he is also there online. So officially, I would like to welcome you and thank you for being here on our platform for this webinar series. So I think it is already 8:32, and keeping in mind the time constraint, we would like to start the program. So then I'll hand over the reins to Dr. Manish Munjal, who will be moderating today's session. So Dr. Manish Munjal, you can take over and now start the session.
It's my real indeed pleasure and fortune to introduce this topic and the speakers to you again. We are in our first part series initiated by the association in Gurugram, Association of Otolaryngology, and it's a very dynamic association. As the secretary of Delhi AOI, I have very fond associations with the association. We have, in fact, twin sisters kind of a situation, and we keep on helping each other in our endeavors, and sometimes we have a lot of joint things. So hope that will continue. In our particular series, Dr. Dinesh Chetri had also asked me what is this about. So we had told him a little about the international webinars that are going to be this, and this is going to be the first one in the whole new armatorium. So today we are starting with the topic in laryngology, and the first speaker that I'm going to introduce is kind of a mentor to me in many ways and a mentor to so many upcoming laryngologists in India. He's none other than the director and the professor chair of Department of Laryngology at Deenanath Mangeshkar Hospital in Pune. And although Dr. Sachin Gandhi sir needs no introduction, but he passed his this graduation in 1988, and then subsequently his post graduation, I think, was in 1992. And after that, he has been at the helm of affairs of laryngology, setting up a real world class laryngology institute within Deenanath Mangeshkar Hospital, which churns out international publications by the hundreds. It's a Royal College of Surgeons of Scotland accredited hospital. Dr. Sachin Gandhi himself was bestowed upon by an FRCS honorary degree by the Royal College a couple of years ago. We all stood proud on that. So, this topic today in laryngology, we have talked about the actually glottic function. That is, we all know that the glottis takes part in voice, airway, swallowing. And also, if we combine all these things into a very vital function, that is protecting the lower airway. So, how we get problems regarding to that and how things are going to be managed presently in a good tertiary institute. This is going to be talked about by Dr. Sachin Gandhi, and he'll talk about clinical management of the neurogenic glottic insufficiencies, which means that we are leaving out things like cancers and structural lesions local. That should be really interesting for us to know. And then later on, I will come to the international speaker. So let me first invite Dr. Sachin Gandhi for our talk. Thank you, sir.
Thank you. Thank you, Manish. And Thank you, the organizers of HAOI Haryana, for inviting me and allowing me to share my experience. Just for a few seconds, I will just share my presentation with you. Meanwhile, what this presentation would include: number one, the diagnostic clips, various methods which are available, and then we'll deal with each and every method in short. Just allow me a few minutes to share my presentation with you all. Slideshow. Yeah. Are you able to see? Yeah.
Yes, sir, we can see your screen.
Yeah. Okay. Let's go. So what are the leading factors which really give patient to have dysphonia with unilateral vocal cord palsy, and they land up in your clinic? The most common in adults is the surgical trauma. Number one being thyroid surgery, as we know. Now more and more patients are coming with cardiovascular surgery. The patients are referred within the recovery of the cardiac, and skull-base surgery. More and more orthopedicians are now going for spine surgery with anterior approach, and these patients are referred to you. So within surgery, I think these have become more common: thyroid, cardiovascular, skull base, and anterior cervical spine surgery. Head and neck surgeries like any big lymph node or schwannomas in the neck. These patients do come with recurrent laryngeal nerve palsy post-surgery. Birth traumas, intubation traumas, giving maybe edema and maybe permanent or long-standing recurrent laryngeal nerve palsy also have been referred from ICUs and long-standing intubation. More and more road traffic accidents, so blunt and sharp traumas, they do come with unilateral vocal cord palsy, which needs further management. Of course, to the central part, there are many diseases, strokes and other kinds, which allow or which get the patients with unilateral vocal cord palsy in your clinics. In pediatric age group, I think brainstem within the brainstem, the fourth ventricle, the Arnold-Chiari syndrome, I have seen few cases. So pediatric population, pediatric unilateral vocal cord palsy, I think you have to see more of central nervous system, get their MRIs done, and rule out all central causes. In pediatric population, around 40% of unilateral vocal cord palsy are because of viral infection, that is idiopathic. So most would recover on their own or maybe with the help of some voice therapy. So as far as pediatric population is concerned, coming with unilateral vocal cord palsy, there are maybe not more than 20% which have peripheral nerve damage presenting as unilateral vocal cord palsy. Then neoplasms, lower airway, lungs, they can come with unilateral vocal cord palsy as a feature. Neuromuscular diseases, I have seen many cases of myasthenia gravis having presentation with recurrent nerve palsy. More and more head and neck cancer patients referred to organ preservation, that is chemoradiation. They too come with vocal cord palsy after the chemoradiation, mainly the radiation. You have to always rule out aortic neurism and cardiomegaly Ortner syndrome, the patients who come with left sided unilateral vocal cord palsy and then infections. What are the presenting symptoms? Dysphonia, that is weak, hoarse, breathy. They do have vocal fatigue, which is quite inevitable. Diplophonia, because of different tensions on both the vocal folds. Pain during swallowing, because there is always an excessive supraglottic activity as a compensatory mechanism, which we are going to see in the slides now. Aspiration may be the presenting symptom. Usually it is a presenting symptom. Weak cough. Chronic patients may come with pneumonia because of unilateral vocal cord palsy. Dysphagia because of central nervous involvement. Breathlessness in few patients which have long-standing unilateral vocal cord palsy with edema or arytenoid prolapse, and bilateral immobile or bilateral superior as well as recurrent laryngeal nerve palsy, and both the vocal cords in a paramedian position. We are going to see as we go along. The management strategy, basically as soon as the patient lands in your clinic, flexible video laryngostroboscopy, you have to just get and confirm your diagnosis. As per the position of the vocal cord, you can just try to find out which nerve has been hampered, either superior laryngeal or recurrent laryngeal, which we are going to see as we go along, and then manage the plan. On flexible laryngoscopy, you can just note what's the distance between the two vocal cords, and then what therapy, what treatment would benefit the patient. As a common investigation to all these patient imaging thing we do is CT scan of the skull, from the skull base to the mediastinum, to rule out all peripheral nerve damages. Skull base, yes, you can rule out the brainstem involvement as well. You can differentiate with them as a central cause or a peripheral cause. Then start planning the management. All these patients, we do laryngeal electromyography just to know what's the muscle potential at the time of presentation, and then you can really know how much recurrent laryngeal nerve have been damaged, what are the chances of recovery, and what therapy you have to give or how much to wait. Then you can do all the blood investigations to rule out all granulomatous and other diseases. Then go in for direct laryngoscopy if you have to medialize the vocal cord, which cases and when, that we are going to see as we go along. You have to palpate the vocal process under GA to differentiate between fixation and vocal cord nerve weakness. As the presentation, what are the patients would show on a video laryngostroboscopy? So basically, they would have a paramedian position, a large phonatory gap. The nerve which really is at palsy would be shorter, immobile, and there would be incomplete glottic closure. I don't know whether you are able to hear, but that's we can hardly hear. Okay. So this is the right vocal cord palsy. There is a phonatory gap and it's in the paramedian position, giving maybe more than 2 or 3 millimeters of the glottic chink, which is available. Because of forceful adduction, the patient applies to have good voice. Patient can have a arytenoid granuloma as well as at presentation. So you have to see to it what the patient has during the stroboscopy. See, you can see the arytenoid granuloma there, which we say or note as a contact granuloma. This is because of the contact hyperadduction. So this is left vocal cord palsy with hyperadduction. There is always going to be compensatory mechanism by the supraglottis in which the patient would have anteroposterior as well as lateral contraction. What we mean by anteroposterior, that is the arytenoids that touch the laryngeal surface of the epiglottis. So this is anteroposterior closure and the lateral closure as well. As we go along, we'll see those. When the patient has these features like the secretions which are really you can see in the piriform foci, then signs of aspiration may be more of the central cause. So this is post CVA and right vocal cord immobility, glottal gap is present. I don't know, audio. Okay, so when you see the salivary, the collection of the this one in the piriform foci, aspiration, signs of aspiration, more of a central cause than peripheral. The peripheral vocal, the cause again. Now you see the mucosal wave on both the vocal cords. This is the pulsate cord, the left cord. See, now when you see the mucosal waves are more on the left side, that is paralyzed side, because there is a loss of contractility of the vocal cords. The whole spasm, the muscle tension has gone. So there would be like fluttering of the vocal cords, which are palsied, which are paralyzed. So mucosal waves are prominent than the normal vocal cord. Okay. Now in pediatric age group, now this is another class which really baffles us, because either congenital or pediatric age patients coming with vocal cord palsy. Now you see the left vocal cord palsy in which there is a arytenoid overlap. Again, the vocal cord looks shorter. See the mucosal layer on the left side. Okay. Now, in the pediatric age group, we'll finish the management as well. Because we have seen More of them are of viral origin, that is idiopathic. The second most is the central nervous. So because they are of viral origin, most of them would recover or they would need voice therapy. The third surgical intervention, what has been described, is injection laryngoplasty, that is fat augmentation. Fat augmentation, the youngest I have done, that is 12 years of age. I think all the pediatric population presenting with unilateral vocal cord palsy, the mainstay of treatment is still voice therapy and SOS fat augmentation if the child is younger than 10 years of age. Patients presenting with change in voice, what kind of voice they would have? So rather than breathy voice, they have a weak voice. And see, the presentation would be bowing of vocal cords or the vocal cord which is paralyzed. And this bowing of vocal cord is because of superior laryngeal nerve palsy, which is going to affect the cricothyroid muscle, which really is responsible for giving the tension to the vocal cord. So you see now the right vocal cord on adduction is showing bowing and inadequate glottic closure. So it is a slight breathiness, vocal fatigue. This is very important. Inability to elevate, or there is no amplitude of the tension or the elevation of the speech or the voice because of loss of cricothyroid activity, which gives tension to the vocal cord and which is supplied by the superior laryngeal nerve. So superior laryngeal nerve palsy would again present with bowing of the vocal cords and weak voice. Again, what's the treatment for this? Most of these are because of viral infection. So voice therapy is the mainstay of treatment. If they have, longer duration inability to recover, maybe because of external blunt trauma, then you can go in for either thyroplasty 1 or thyroplasty 4. That is what we called is as the tightening thyroplasty, the tightening method. So you elevate the tension in the vocal cord by stretching the vocal cord. So cricothyroid approximation, that will stretch the vocal cord and give good glottic closure and good voice. So basically 90% of superior laryngeal nerve palsy patients would recover with voice therapy only. Maybe 5 to 8% would need surgical intervention, either type 1 or type 4 thyroplasty. Now, the breathlessness. As I have told, we are going to see in a clip with arytenoid prolapse as a compensatory mechanism for aspiration. They can have, because of the arytenoid prolapse, breathlessness, which we are going to see otherwise in the next few slides. What's the other reason for the neurological cause affecting both the vocal cords? So when both superior laryngeal as well as recurrent laryngeal nerves are affected, then what they would need is both the vocal cords are in the paramedian position. It is absolutely breathy voice, inadequate. Inadequate in the sense there is no glottic closure, there is absolutely no movement, and this patient can have breathlessness as a feature because of aspiration pneumonia. And of course, dysphonia. So what's the treatment? Again, voice therapy. You can do unilateral thyroplasty, fat augmentation, but maybe that would give breathlessness to the patient because of the compromise of the glottic chink or the breathing space. So what's the treatment actually has been, this is maybe theoretical, I have done in 1 or 2 cases, is you can augment bilaterally or do bilateral thyroplasty with one-sided posterior chordotomy. So get them together and then create a air passage here. So difficult to treat cases. What are the compensatory hyperfunctional behaviors? Ventricular phonation. So ventricular hypertrophy. You can see mucosal waves. This is compensative. What could be the we have already seen anteroposterior closure. This is again for dysphonia as well as to prevent aspiration. So this is a compensatory mechanism. Now you should know and note these during your initial video laryngoscopy, because what is important is you have to give voice therapy before going into any intervention, just to take care of relieving these patients of these compensatory mechanisms. These are the CT scan finding in unilateral vocal cord palsy. As far as recurrent laryngeal nerve palsy in adults, dysphonia, swallowing, breathlessness. Surgical management when the voice therapy fails would be again fillers or getting surgically moving the cord to the midline. The temporary intervention would be with fillers like an office-based procedure or injection laryngoplasty. Fat augmentation, I think in my experience, it is of longer duration, not permanent, but maybe in between those. As far as permanent is concerned, is again medialization thyroplasty 1 described by Ishiki, retinoid repositioning procedures, and again reinnervation, which we are going to learn in a few minutes from now. Apart from video laryngoscopy and imaging, you will have to go in for electromyography, which we do in these patients to gain the muscle potential in the vocalis muscle and other muscles beforehand, to know about the existing position, the chances of recovery, and what procedure to go in for. So you can monitor the recovery, establish real prognosis, and of course, surgical outcome. These are actually the procedures. Maybe we'll learn more in this one during this one, but just I'll show this one. This is the palsied cord. This is the normal potential issue. You can do this PFT in this patient just to know the airway and what kind of closure is there with the patient. Voice therapy. This is the first line treatment when the patient comes in quite early, after maybe within 3 weeks to 12 weeks. So what you have to achieve is good adduction with all these methods. Breath control with abnormal breathing, expiration against resistance, and as I've seen, to relieve ventricular hyperfunction. So this is very important. So patient already who comes after 3 months to 6 months has already developed compensatory mechanism, and those have to be relieved. Swallowing therapy, when the patient comes immediately following a road traffic accident, the first presenting symptom would be aspiration rather than dysphonia. And you have to treat these patients with swallowing therapy, like supraglottic swallow and all these methods to get rid of the swallowing dysfunction in all these patients. Okay, these are different methods available. Now there are those who don't want to, go in for surgical intervention or other methods. There are professional voice users who can have these voice amplifiers which are available and as low as rupees 1,000 on Amazon. The transoral methods, injection laryngoplasty in the patients who has got phonatory gap less than 2 millimeters, patients who are fit for general anesthesia, when you have to go in for fat augmentation. Thyroplasty 1, when phonatory gap is more than 2 millimeters or there is arytenoid prolapse. The indication for office-based procedures, fillers are the amount is less, especially in patients who need who are on palliative care for a head and neck surgery or head and neck cancer, patient coming with lung cancer following all this chemoradiation, high risk, restricted mouth opening and restricted neck extension. There are many of these who will come to your clinic. What are the benefits of early injection laryngoplasty? If the patient comes in 6 weeks or 3 weeks, whether you are going to give or do injection laryngoplasty or going to wait. Now there are two factors. If patient has professional commitments, maybe you can think of injecting them as an office-based procedure. If you inject within 3 months or as patient presents, then it can help the compensation as well. I think it will give good voice till there is a normal or spontaneous recovery. This is pre-op, and there is with office-based procedure, there is immediate recovery or the results are available with good approximation on table. So that's the advantage of office-based procedures. There is good approximation available. Injection laryngoplasty, actually, there are various methods which can give to inject as an office-based procedures. We are going to see them as we go along. What are the materials available? The safest and what we use is the fat, which is an autologous fat. Some people use fascia collagen as well, but autologous fat is the easiest and safest material to inject. Synthetics are available in the market, silicone, Teflon, and many others. The disadvantage going foreign body reaction and Teflon may be carcinogenic. So these are short reacting. These are only for shorter duration, 3 to 6 months. Foreign body reaction. So only those indications which you have seen, not fit for general anesthesia, for palliative care, for head and neck cancer, you can go in for office-based procedures with synthetic material. For all others, fat augmentation is best as well as injection laryngoplasty is concerned. These are various already available. There are 3 routes by you can do office-based injection laryngoplasty. Transthyroid, the midline of the thyroid cartilage. You need thicker needle, thyrohyoid or cricothyroid from below and from above. When you have to do it under flexible laryngoscopic visualization, then it's easy to go from below and inject. But easiest to do again is from the transthyrohyoid. So this is the short clip. We are doing it with the flexible laryngoscopic control. So you have to inject in the midpoint and see the closure. You can check it on the table during the procedure. Then for the younger patients, you can use trans thyroid also. Now, which patients, which material I will use for trans thyroid is when I want to inject fat, I will inject trans thyroid method. Time. So I'm injecting actually, and this is a video. See, this is the closure available here. Okay, autologous fat. Now this is I'm doing it quite regularly. It gives wonderful results, immediate results, and maybe long lasting. Not maybe, it surely is a long-lasting procedure. I never tell the patient it's going to be permanent, but I always tell it's going to be long-lasting, that is 10 to 15 years. And this I have done with MRI control till 5 to 10 years, and use data which already I have published in many journals. I'm just going to show you, I mean, how I inject the fat. So you just have to take the fat from the periumbilical region, take the fat globules without any connective tissue, cut them with the scissor. I'm not going to show you the clips now. Remove all the connective tissue like muscles, only the fat globules. Just with the mortar, you have to just make a paste of it and take an insulin syringe, and you have to put that fat in this. You can add insulin in that. What are the advantages that we are going to see? But then this is loaded into the tuberculin syringe, which is 1 cc, and with the needle we can inject. I'm going to show you the clipping also. But this procedure has to be done under GA, and you have to inject 30% more than the midline to have long-lasting and adequate glottic closure. These are various I mean, methods are available: liposuction, centrifugation, but I think I always prefer surgical excision for all these points because it to be long-lasting and having those materials or the biomaterials available to the tissue which we have injected. So just anterior to the vocal process, I have prepared my needle. Inject the fat. And it should be crossing the midline 30% more than the complete glottic closure. Around 1 to 1.5 cc EOC is required. You can seal, when you remove the needle, you can seal it with KTP laser, but not necessary in all the cases. And endoscope is preferred over microscope, because you can take the endoscope quite close to the vocal cord and manipulate the needle with various angles and reach the vocalis muscle or the paraglottic compartment and inject the fat. Now, how the patient present with breathlessness with unilateral vocal palsy. See, this is the arytenoid which is prolapsing and causing airway obstruction.
बस लंबी सांस लीजिए आराम से.
So this is the prolapse, and
बस लंबी सांस लीजिए आराम से.
sorry. So this is the prolapse. So what I have done is I have excised this arytenoid cartilage with the CO2 laser, and I have augmented the right or pulsed vocal cord at the same sitting. And this is the post-operative stroboscopy. Adequate glottic closure and good airway. If patients do have presentation or surgical intervention or fat augmentation, maybe more than 12 weeks, more than 6 months or 1 year, then there is always going to be atrophy of the vocalis muscle, in which you can inject platelet-rich plasma as a growth factor along with fat uh, to maybe have a growth factor and taking care of the phonatory gap as well, or giving the bulk to the vocalis muscle. Insulin actually prevents lipolysis by stabilizing the fat, and you can, with the fat, you can always push in the insulin with the fat to medialize the vocal cord. I think the results are quite good. And what's the advantage over thyroplasty is it gives bulk as well as medialization. It maintains the mucosal wave of the vocal cord, which gives good phonatory outcome. Again, the risk factors would be the depth you have to check. It should not go into the more of the subglottis or into the ventricle or into the false vocal cords. So subglottic, supraglottic spread should be prevented. In few of the cases it has been noted, not in my series, but it can just travel from the thyroid or this fascia, I mean into the neck also, presenting as a subcutaneous emphysema. Good approximation after 1 week, and as they recover with, see now here you will not see the mucosal waves, that's only glottic closure, but as they recover with the mucosal wave, that takes around 3 to 4 weeks, the voice outcome, phonatory outcome is quite good. So it gives good bulk and good phonatory, prevents the mucosal waves and gives good vocal outcome as well. I will just finish. And long-term results are really excellent, and I have followed this. And now, what could be the limitation of fat augmentation? It's not going to medialize the posterior 1/3 of the vocal cord because it's a cartilage there. So only the usefulness for anterior 2/3 of the soft tissue membranous part of the vocal cord. And for that, if there is arytenoid prolapse, then you have to do thyroplasty with arytenoid abduction. So this is MRI and all these things I have following these patients, and it shows presence of fat in more than 5 years of fat augmentation. So you have seen this. Now a little bit on thyroplasty. Thyroplasty gives.
Sir, I would like to request we crossed a little bit of time. If you could sum up in a minute or so, less than a
2-3
minute.
slides. That's over. Yeah. So advantage of thyroplasty is permanent. You have to just maintain the level, and only disadvantage would be the vocal atrophy, or the atrophy of the vocalis muscle is going to continue, and it's not going to offer any bulk to the vocal cord as we compare it to the augmentation. You just have to remember few things. Should be at least 5 millimeter away from the anterior commissure and at least 1 to 2 millimeters from the lower border of the thyroid cartilage. These two things you have to see to it. This has to happen to have a good outcome of from the thyroplasty 1 procedure. If there is a arytenoid prolapse, then you have to do arytenoidopexy or mobilization of the arytenoid cartilage and suturing it to the cricoid cartilage, or you can do thyroid arytenoid adduction. There are various materials available, radius and bovine. The commonest we use is the silastic block, which is available in all the theaters. But these various are available and have been used in many clinics. The newest which has come is a Vion, which is actually a balloon which is injected with saline. So you can just look into with a stroboscope and inflate the balloon whatever is required to have a good glottic closure, and then that will remain permanent. So this is a voice implant. I think next month we have got a demonstration here in April 18, 19, 20th voice course in Dinanath. Yeah. Risk factors again, infection, bleeding, contractitis, and extrusion of the graft, which we are aware of. Okay. So these are all methods and publications. Thank you very much for the kind listening.
Thank you, sir. Listening to you is like literally looking into the encyclopedia of voice. And yeah, I can see your affinity for the injection laryngoplasty, but that's what we would say our whole physiological treatment is all about. And injection laryngoplasty also, I would vouch, is a fantastic way of giving a very good physiological voice to the patient. So amazing. There are a quick question, although we are overshooting time, but there were a few questions. So I'll just put in a question from our very own area renowned laryngologist. In fact, I should not insult by saying area renowned. He's renowned now all over India and abroad, and that is Dr. Shashidhar from Artemis. So there is a question about him asking as to what is the utility of this EMG in assessing the vocal cord palsy? I know you mentioned that in a slide in your presentation, but I have found EMG, even though we have EMG in our institute also, quantifying and having a protocol for EMG, reading an EMG, find these are difficult things, and if there is any light on that, that would be great. And one thing is that although we did not touch too much of it, but in motor neuron disease, if you have bilateral vocal cord palsy and person is there and it's not very severe, but voice is not there, how would you think of managing? So these two questions are there. There was one more from Dr. Rupinder Kumar, investigation for DLN palsy, but I couldn't understand that. So I'll ask the first two questions. LAMG, how do you interpret and management of bilateral vocal cord in motor neuron disease? What do you think?
Yeah, I think number one, EMG really it's very useful. It takes time to really learn and how to read the EMG. Now, when we started doing EMG, we used to, I mean, they still now, they go to the neurology OPD, but they have learned to really do the EMG on their own. They do the EMG, but now still it is reported by the neurologist.
Okay.
That is number one. But now we have just, I mean, then our individual, because see, we are doing EMG for almost 2 or 3 cases per day. See, you just have the patients in your OPD, but when you start knowing the utility of EMG, then you really go on. And then one of my fellow has already had the classes from the neurologist, and now we are going to do it within the clinic. Our own, we are going to already order, and it will be installed in next 2 weeks. And we are going to do it ourselves and report ourselves. That is number one. So really, it is very useful, easy to do, and all my fellows really do them without any problem. What's the utility? Utility is very important. A post-thyroid case, when it comes, then whether the nerve has been cut or whether it is edema, that you can know when you do the EMG. That is number one. Number two, you can monitor. So maybe in the first visit, you can do EMG, and maybe you can call back the patient under voice therapy after 1 month, repeat the EMG, and you see the difference between the action potentials. If there is an improvement, then you can continue with voice therapy. So you can monitor the therapy. And
so this is going to be this is a surface EMG we are talking about all the time and a routine this thing, or it is the you have to go in.
We have to go in.
Okay.
We have to go in.
And is there a quantification to it also, or is there a qualitative more of a answers that you get?
Yes, yes, there is a quantification, with the graph and everything. As we have seen, the normal and absolutely there is no action potential. So the clip which I have showed, there is absolutely no action potential there. That means most likely the nerve has been cut there. Okay. So actually you can monitor when the patient is under voice therapy. Number two, there are patients who show normal action potential. So maybe it's a edema. So you can give steroids and then maybe that. So there,
Wonderful.
actually, as you start,
Any two words on the next questions? The management of bilateral vocal cord weakness in MTD, and then definitely we'll move on to the next speaker.
yeah, I
Yeah,
think,
managing.
yeah, this motor neuron disease, very difficult patients to treat. So actually, if they are advanced, then best thing is to do tracheostomy and keep them on swallowing therapy.
Wonderful, wonderful. Thank you, sir. And once again, hearty thanks from myself. Of course, through the meeting, we'll have a vote of thanks again from the next from the Gurgaon AOI also at the same time. I have to move on to the next speaker now, and I'm
Sure.
sure you will enjoy his talk as well as you always do.
We-
So, to everybody, I'm introducing back to you. He's also not somebody who is unknown in this part of our world now. I mean, I could go on and on about him. Dr. Jinesh Chetri is a laryngologist, and he is now the director of the UCLA Swallowing Disorders Program, the prestigious UCLA Head and Neck Cancer Survivorship Program, and also co-director of the Laryngology Program at UCLA. Enough for being great pride from this part of the world. And at the same time, he's got a great humanitarian touch to his work. As Shashidhar is, who is even more close to him, he has his philanthropy cycles all embraced around us. And not only we get him as a regular in teaching schedules at conferences all over, but also in the his home country of Nepal, where a lot of treatment camps for children with airway disorders he's been doing. So I'm very proud to bring back my friend and a very very good human being, Dr. Dinesh Chetri, for the talk. Dr. Raman, could you put him on for the talk?
Yes, sir. So you can share your screen.
I'm on.
Yeah.
Great. Thank you. Thank you, Manish, for the invite. And I also want to thank Dr. Bhushan, Dr. Ravinder for inviting me for this special event. I know it's very late there. It's early in the morning in Los Angeles. You guys might have heard about the big fires. It was very bad, but it's now all gone. We're doing well. I'm going to share my screen and let me know if it's not working. You can see my screen, yeah?
Yes, sir. We can see your screen presentation.
This here. Okay, so I'm going to go right into my talk. I'm going to talk a little bit about clinical applications of laryngeal reinnervation. And if you think about the applications of reinnervation in otolaryngology in general, we have applications in laryngology in terms of the treatment for vocal fold paralysis, unilateral and bilateral, and also significant application of reinnervation in adductor spasmodic dysphonia. There are also applications in facial reanimation, as you may know. And in the past, there was some significant reports on sensory reinnervation in free flaps, which then I have not seen many reports of anymore. So let me talk a little bit about the application of reinnervation in unilateral vocal fold paralysis. So as Dr. Gandhi very nicely gave you this nice overview of treatment of unilateral vocal fold paralysis, this would be a very typical case.
Good. Beautiful. Low to high. E. E. Good. Swallow and swallow.
So essentially, this is a patient you will see with unilateral vocal fold paralysis. And then the question is, well, what should you do next? Similarly, you may see a pediatric case. There's a 4-year-old boy who suffered a vocal fold paralysis after esophagectomy. The voice is somewhat breathy.
One, two, three, four, five, six, seven, eight.
So it's still a pretty good usable voice, but you know, he's about to go to school and is conscious about his voice, so you may want to do something about it. And then the question is, you know, what is the next course of action? Just to be on the same page, when we talk about paralysis, we talk about complete immobility of the vocal fold due to neurogenic etiology, although we often say paralysis when we mean that the vocal fold is not moving, but we want to make sure that we know what the etiology is, and particularly when it comes to reinnervation, we want to make sure it's a neurogenic etiology. In contrast to that, paresis can be anything. It just means restriction of motion. It can range from very, very subtle findings where you may only see some mucosal wave asymmetry on video stroboscopy to very obvious dense paresis where the restriction of movement is obvious. And then there's a big question about, can a paretic vocal fold be reinnervated? Something to think about when you see patients with paresis. This has already been covered by Dr. Gandhi. What are the etiologies of vocal fold paralysis? In adults in general, nowadays, we are no longer seeing them from thyroidectomy as much, but I think from non-thyroid surgeries like cervical spine surgery, skull-base surgery, thoracic surgery, etc. So these are the main things I think about when I think about what I want to use for treatment of unilateral vocal fold paralysis. So ideally, we would want to be able to give back physiologic movement, which we yet cannot do. So that is the two unhappy signs there on the right. We want to bring the vocal fold in a phonatory position, which means mostly in the medial position in the midline, which we can do pretty well with a lot of the things we've already talked about. We want to give the vocal fold bulk. We can do that with many of the techniques. There's a very significant research done on what should the shape of the medial surface should be that we want to recreate, because all the vibration that you see, although when you do a video stroboscopy, you're looking at the vocal fold vibration from a superior view, most of the vibration is actually occurring on the medial surface, which you actually cannot see. And there is literature on what that surface contour should be that is ideal. And that's something to think about if you're particularly doing a thyroplasty or even doing an injection. You know, what should you try to make the contour to be, as opposed to just bringing the vocal fold to the midline. And then finally, you really want to give the muscle tone to the vocal fold so that it can vibrate very well and effectively. And we are sort of can do that, but most likely with reinnervation. So these are the main possibilities for treatment of vocal fold paralysis. So obviously speech therapy, we talked about injection augmentation. You can do framework surgeries like a type 1 thyroplasty and adduction procedures. And in regards to reinnervation, the literature started with doing neuromuscular pedicle reinnervation. There are some reports on direct nerve implant, and then finally a nerve-to-nerve anastomosis. And currently we're mostly doing ANSA to recurrent laryngeal nerve anastomosis. And also you want to go back and start thinking, you know, which reinnervation technique is the best? And I would say that a lot of this basic science research has really not been done, and that's something I'm very interested to know, because especially for paresis, some people are advocating doing reinnervation for that as well, and we have to say, does that really work? And that still requires some basic science. So why reinnervate? Well, for optimal voice production, we talked about the need for glottal closure. That's adequate. You also obviously need adequate aerodynamic forces, a good, airflow from the lungs. You need to have normal vocal fold histopathology. So somebody with a scar that you medialize will still not sound very good. And then this is the concept that is very relevant to reinnervation, which is that the vocal folds to have a left-right symmetry. You want symmetry in muscle, the body stiffness, and also symmetry in the tension of the vocal folds. So as you know, after denervation, the laryngeal muscles atrophy, they lose bulk. That leads to then decrease in mass and tension, which then leads to an asymmetrically vibrating larynx. And we know that significant loss of mass and tension leads to abnormal phonatory output. And so if we could restore the mass and tension of the denervated vocal fold, you will improve the vibratory symmetry and therefore improve the voice. And I think the literature shows that laryngeal reinnervation has the best chance for a normal voice. Also, if you do a type 1 thyroplasty and you have a practice for a long enough time, what you'll notice is that patient may come back to you 10 years down the road, and they will now have some worsening of voice. And then when you take a look, what you realize is that over time, there has been denervation atrophy of the vocal folds as the patient is aging. And then at that point, you're like, okay, maybe I need to do a revision thyroplasty, but you could have done a reinnervation 10 years back, and you would have countered this long-term atrophy problem that you will face later in your career. Now, having said that, obviously this surgery is not done very commonly. And then the question is why, right? Why are we not doing this if it is really true that this surgery has the best chance of giving you the best voice? Well, there are many reasons for when we don't go for for one surgery that's been recommended. Well, here are some concerns that have been raised. There's concerns that when you're completing the laryngeal nerve paralysis by cutting the recurrent laryngeal nerve that is still there, you are essentially removing some innervation that was already there. And even if it's synkinetic, should you be cutting that? Why do I want to do that? The other thing is, as you already heard from Dr. Gandhi's talk, well, we have so many good surgical options. We have thyroplasty and adduction and injection. And, most of you will feel that, well, I can just get a really good result with my thyroplasty or my injection. And why should I do reinnervation that is different or more difficult or whatever the reason might be? There is some thought that there are no large studies proving that reinnervation is better. It's not exactly true, but one of the problems we have in laryngology is that it's very difficult to rate voice quality. If you do a acoustic measure, a very soft voice, but that's kind of clear, will sound much better acoustically than a voice that's loud and maybe people can hear you, but it's got a little bit of roughness. So one of the difficulties in trying to say, do this or do that surgery is that we are just not able to do a comparison between these procedures. Because we don't have, like the otologists have a audiogram and the laryngologists don't have a vocogram. And if we could work on a methodology that is reproducible amongst everybody, then we can really say, hey, my thyroplasty or my injection was not good as this or that. So it's something to just think about in terms of the future. Now, the biggest reason I think is this one: the outcomes are delayed. It takes some time, between 3 months to 8 months to 9 months for the reinnervation to take effect and to start hearing the difference. And most of us are just not don't have the time. The patients don't have the time. We don't have the time to wait that long. So again, if you choose to go with reinnervation, really thinking about a patient long term. It is technically difficult, not really, but it is a more technically, there's more technique involved, especially if you don't do it, you have to learn it. There may be a time limit to reinnervation after surgery. And as I said before, I think the research will show you that it works very well, but all of these other things are barriers to using reinnervation in your surgery. Just wanted to put a couple of slides in regards to what's different in the pediatric population with unilateral vocal fold paralysis compared to adults. The main etiology is cardiothoracic surgery. The kids are better compensated for their paralysis. They have a greater potential for recovery. And so there's going to be a little bit less of a urgency to go ahead and do something right away, because a lot of these paralyses actually take up to 2 years to improve. So there is some time to think about recovery, and there's time to see how the child is recovering before you go on to doing some procedure. The only exception I think might be, you know, kids who have undergone patent ductus arteriosus ligation, because in this population, the research shows that the resolution of vocal fold immobility is very, very low, like 3%. So most likely, if a child has had patent ductus arteriosus surgery, it is unlikely that child will recover. So you may want to think about doing something earlier. So what can you do in a pediatric population, right? We can do the same things as you did for the adult, but the framework procedures like doing a thyroplasty or adduction are not options, and therefore reinnervation is a really good option for the child because the reinnervation will grow with the child and really provide a long-term solution to this problem that none of the other procedures actually do. So framework surgery in pediatric vocal fold paralysis is limited because of the and therefore and then injections are really not long lasting. So this is a population that really benefits from reinnervation. So having said that, I'm going to go through a very few slides about reinnervation, how to do it. First, you have to feel comfortable finding the ansa cervicalis nerve. It's actually not that difficult to find if you are comfortable finding the internal jugular vein. If you find the vein and you have a nerve stimulator, you'll see a little white structure coming down the area. And you can see on the left here, there's an anterior limb and a posterior limb, and then they come together to form the loop. Ansa means loop in Latin, so they come together. And usually you want to go under the omohyoid muscle and continue to find the nerve that goes to the thyrohyoid muscle or the sternothyroid muscle and dissect it all out and to a length that allows you to rotate this nerve over to the larynx. Once you are used to doing neck surgery, it should be fairly straightforward. What is the optimal timing, right? It depends on first, you're recognizing that this vocal fold paralysis is permanent. And as I said before, time depends on the etiology. Somebody who has had a neck surgery would be a candidate much earlier, maybe as early as 6 months. Whereas somebody who has, you don't know what the status of the nerve is, you're going to wait maybe a year, maybe 2 years before you do a reinnervation procedure. Ideally, you want to do this within 2 to 3 years of paralysis, but as you know, the larynx really never is completely paralyzed, meaning that if you were to do an EMG on a paralyzed vocal fold, you'll still see EMG activity in many of the patients. So you know it's not completely paralyzed, and that allows you to actually reinnervate the larynx beyond this 2 to 3 years golden window compared to paralysis in the limb muscles, for example. And obviously, as I said before, the younger the age, the better it is because the reinnervation works really well in younger patients. And who's the wrong patient? I personally tend to do reinnervation less if the patients are older. And then the age is debatable. So let's say they're 60, 65, it's less likely to work. Less than 40, I almost always recommend reinnervation. There is a gray zone between 40 and 60. Well, you could go probably either way in terms of a recommendation. If the patient has dysphagia and aspiration as the main symptom, well, reinnervation alone is not going to fix that. So you want to do a medialization procedure, even if you're going to do a concurrent reinnervation procedure. Also, if the patient has a very large glottal gap, the general consensus is that reinnervation alone will not fix very large glottal gaps, and you want to do a concurrent medialization procedure. So I tend to do like an adduction procedure with laryngeal reinnervation. The technique, as I said, involves generally general anesthesia. You want to choose the correct side because you are going to cut that recurrent laryngeal nerve, so make sure you're choosing the correct side and not give the patient bilateral paralysis. You make a horizontal neck incision at the level of the cricothyroid membrane. You will find the ansa cervicalis, as I said before. I personally perform an adduction procedure most of the time because patients will have an immediate improvement in voice. And then you are going to perform an anastomosis of the ansa cervicalis that you can kind of see in the cartoon here to the recurrent laryngeal nerve right next to the larynx. You want to go as close to the larynx as possible so that those axons don't have too far to travel. You have to do this either with a microscope or some loops just to do the nerve innervation. And here's an example of finding the ansa cervicalis. And then this hook is actually on behind the thyroid cartilage. And I only show that because I'm doing an adduction. Otherwise, you can find the nerve in the tracheoesophageal groove. And here's an example of where the nerve is if you are ever concerned of where to find it. As you know, the recurrent laryngeal nerve actually enters the larynx just below the cricopharyngeus muscle. So here's the cricopharyngeus muscle. And if you can find that muscle, then you know the nerve will be just below that in the tracheoesophageal groove. Now, if you're going to do an adduction procedure at the same time as I do, I'm doing my adduction up here. This large muscle, hope you can see my, I don't know if you can see my mouse. Maybe not. If not, I would say the big muscle here is the posterior cricoarytenoid, and then the thyroid cartilage is over here, and that white structure going between the joint, the cricothyroid joint and the posterior cricoarytenoid muscle is the nerve. There's only one nerve there. If you dissect there, you find a white little structure that you can follow, then it's always that nerve. And then I will cut it right about the level of the cricopharyngeus muscle, bring it over, and then do the anastomosis as you saw before. So here's another example of doing the, it's the left neck, which means that the strap muscles are on the left, the thyroid ala is over on the left side, the ansa is coming from the right side of the picture towards the left, and the anastomosis is somewhere in the middle. You can see there is the ansa is about twice the size of the recurrent laryngeal nerve around that time. Here's another case of a right neck. You can see the posterior thyroid ala. I'm doing an adduction, which is why this is all opened up. And the ansa is the anastomosis, the recurrent laryngeal nerve, which I found behind that joint, as I just mentioned. And the purpose of showing you this picture is to say that there are two, there's the superior laryngeal nerve is right there. And if you're doing it this way, you want to be careful that you're not cutting that nerve because you still want that to work. Okay, results. Many studies on reinnervation, but this is probably the best you can get. This is from Paniello in 2011. What they did was they randomized patients into a thyroplasty versus reinnervation. And if you look at this group all the way down here, on the left, it's a Grabus score between 0 and 5, I think. But 0 is normal voice. So the only group that had a normal voice was reinnervation group, and particularly in the younger age group. So this is a good example of, thyroplasty, better maybe for older patients, and then reinnervation definitely good for the younger patients. The worries about denervating the larynx, we had a little robust conversation about EMG, so that's something to think about. In this study, they also looked at the EMG class. So it was 0 would be like normal EMG and 5 would be the worst EMG. And if you look from the pre-op to the post-op, you really never made anybody worse by cutting the recurrent laryngeal. Dr. Lalit.
Hello, Haji sir.
Okay, so I'll keep it going.
We are having some disturbances. Please switch off whoever is not listening. Yeah, thank you.
So you can see that the EMG class really never got better. The arrows are all going down. That means you didn't make them worse and you only made them better. So this is why I think it's very reasonable to go ahead and cut that recurrent laryngeal nerve, even if you had some consideration that maybe you're cutting the nerve that's already there. Okay, I'm going to talk very briefly about the two other conditions. Hopefully I'm not going too late. Okay, so how about bilateral vocal cord paralysis, right? In bilateral vocal cord paralysis, it's a very difficult condition to treat, as you know, and the main consideration is the airway. We have many surgeries that's designed to improve the glottic airway in bilateral vocal cord paralysis. But in regards to reinnervation, here are the options. You can use an ansa cervicalis, superior laryngeal nerve, or phrenic nerve. I'm going to talk a little bit about what allowed some of the reinnervation surgery to be possible. One is that in the 1980s and 1990s, we learned a lot more about the intralaryngeal anatomy of the recurrent laryngeal nerve. So earlier I showed you this picture over on the left where the nerve is going into the larynx, intralarynx, just behind the cricothyroid joint next to the posterior cricoarytenoid muscle. Well, what happens to this nerve as it goes further in? And a lot of the studies that were done in the 80s and 90s were to show that there is a branch going to the PCA here where the arrow is. There's a branch going to the IA. And then further up with the big arrow, the branch is going to the thyroarytenoid and the lateral cricoarytenoid muscles. And this is now looking at this muscle going into the larynx from the side view. You can see it coming behind the joint where it says A, and it's going in. C is the thyroarytenoid muscle, the vocal fold muscle. The nerve is going into the muscle there, and also there's a branch going to the LCA. So this kind of allowed us to understand that you can actually target the nerves further into the larynx and that you didn't need to be afraid of going in there. So in regards to the reinnervation for bilateral vocal fold paralysis, it would be amazing to be able to just have two nerves, one that drives the adductors and then one that drives the abductor. For example, you could do a phrenic nerve to the RLN for the abductor, and you could do a ansa cervicalis for the adductor. The problem is this. So as you can see, as the recurrent laryngeal nerve goes in, here you can see a branch going to the posterior cricoarytenoid muscle, which is the only abductory muscle of the larynx. But then there's a problem. There's a nerve going also just behind that, going under the PCA muscle, and then keeps on going, and it goes and innervates the interarytenoid muscle. So you have a adductor branch and an abductor branch that's very close, and sometimes this adductor branch actually goes it goes as a branch of the PCA nerve. So there's not a great way to just innervate the abductors. Here's a dissection showing the same thing. Here's a recurrent laryngeal nerve behind the joint. And as you follow the nerve superiorly, actually the joint is right there, and there is a branch to the PCA and there's a branch to the IA that are very, very close. And you can't really do much to this nerve unless you dissect under the PCA muscle, which you obviously don't want to do. So one other way to get through this nerve is to go cut the nerve right at the top of the cricoid. So you have to expose the top of the cricoid and just take a knife and just dissect along the superior border, and it'll cut that nerve that adducts it. So because of that, this is actually the schematic of reinnervation for bilateral vocal fold paralysis as done by the French group, by J.P. Marie. And you can see that there are a couple of issues that I think, one is that you're taking the root of the phrenic nerve at C3, then you have to put a jump graft that goes all the way to the PCA, and it's a direct nerve implant. Okay, so you have to ask, well, what does the jump graft do in terms of the potential for reinnervation? And second question is, does the nerve as a direct nerve implant to the muscle, does it work very effectively? And then in this schematic, you'll see that they take the anterior branch. Actually, this branch over here is the branch to the thyrohyoid of the hypoglossal nerve, and that is used to reinnervate the adductors. So in short, I think personally that the direct nerve implant and the jump graft are some limitations. I mean, we don't have anything better, but in terms of, currently, those are the limitations. So for that reason, I think some of the results are variable when you get reinnervation for bilateral vocal cord paralysis. But here's a good one. So there's a patient at baseline who doesn't have much movement. This is about 5 months. And you can start seeing some movement. And then 12 months. Better. I mean, it's not going to be perfect, and oftentimes what I've seen from the results is that one side tends to reinnervate better than the other side, but it probably in this case is adequate for decannulation and the patient still has a good voice. But again, it takes a long time, and sometimes up to 18 months for this to work. So I want to show you a couple of pictures of using the superior laryngeal nerve also as a motor driver for the PCA. The cricothyroid muscle has respiratory function. Multiple animal studies have shown that the cricothyroid activation activates with respiration, and that the activation of the cricothyroid actually corresponds with activation of the posterior cricoid muscle. And so that kind of makes you think, well, maybe the external branch of the cricothyroid muscle, which innervates the, that may be something we can use to reinnervate in bilateral vocal fold paralysis. So we had a couple of cases of patients who had thyroidectomy and had bilateral paralysis. And this is a schematic of something that we did where you can take the external branch of the superior laryngeal nerve here. And remember, I showed you a picture of the recurrent laryngeal nerve at the bottom, going up, 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 and then the PCA is right over here on the left, and then the anterior branch is going anteriorly, and the thyroid ala is on the right where that little instrument is. And we've removed a little bit of the cartilage of the thyroid ala so we can identify the anterior branch. Well, now you can take the ansa cervicalis here on the left going to the right to the anterior branch, and then the external branch of the SLN is going to the PCA branch, and then we had to go up there and at the level of the cricoid cartilage and cut that branch. So it's a lot of work, but you know, over time, if you were to wait long enough, you start getting a pretty good airway. And in both of these cases, we had the patients decannulated and did well with no dysphagia or aspiration. So this is something you could think about, which is a little bit less complicated in regards to doing it as opposed to the French technique. Now, ideally, we can give the patients adduction and abduction. And the abduction, since it's not very robust with the current techniques, you know, is there a role for laryngeal pacing? In the past, a lot of the issues had to deal with the electrode contacting the muscle and resulting in a lot of fibrosis or the electrode breaking down. I think some of these things are still a problem, and there are studies being done currently, clinical trials in the US to try to figure out what is the role of pacing, but we still need long-term studies, and patient recruitment is a big challenge for both reinnervation bilateral paralysis as well as this, because as you know, most patients just want something done. If they can breathe, that's the most important thing, and they don't have time to wait a year to see the results. Okay, if I have time, I'm going to give you 5 slides on adductor spasmodic dysphonia, if that's okay, Manish. So I want to talk about a great
Yes, we'd love to have, but a quick one. Yeah.
Okay, all right. So I'll just go quick, okay? I want to show you some results for spasmodic dysphonia. As you know, adductor spasmodic dysphonia is a central nervous system disorder. There are voice breaks associated with EMG activity. Aberrant nerve signal comes from the brain. The vocal cords are hyperadducted. They press too much. They create a huge increase in resistance at the level of the vocal folds. And then because of that, we cannot match the subglottal pressure, and you have airflow breaks, which is then perceived as voice breaks. So what is the current treatment? We're all adjusting the biomechanics of the larynx to reduce this adductory force. And we can do that by mechanically reposition of the vocal folds, like a type 2 thyroplasty, or physiologically by altering the nerve input or the muscle tension. Botox works the same way. So we do this procedure where we denervate the larynx and then reinnervate the larynx with ANSA. And it looks like this. So just to get to the point, okay, we make a window on the thyroid cartilage. We cut the nerve going to the TA. We cut the nerve going to the LCA. We take the ansa cervicalis that I presented before, anastomose to the TA. You take the RLN and you just exteriorize it outside the larynx. So I'll give you just one example.
I'm interested in having an operation for my throat.
Okay, good.
For my larynx.
Early one morning, a man and a woman rambling along a 1-mile lane, running near Rainy Island Avenue.
Typical patient with adductor spasmodic dysphonia.
Since my
Post-op.
operation, I can speak without a spastic voice. And I can just speak basically the way I spoke before, with the exception of my volume isn't very high. And
so I hope you heard that.
Office.
Just go through that. And so it's actually very exciting that, you know, this surgery works really well, and it's a good answer to long-term resolution of adductor spasmodic dysphonia. It's interestingly a condition that's present throughout the world. Every country in the world seems to have spasmodic dysphonia. And if you don't have access to Botox, and if you're really looking for a long-term solution for this patient, this is an excellent operation to consider, and that works. And I know it's very late there, and I will end it here. Hopefully, if there's any questions, I'm happy to answer it. And thank you again for allowing me to take some of your time today.
Excellent, excellent. What can I one ask more for? I mean, you covered basically everything in terms of reinnovation. Thank you, Dr. Chetri. And one comment I must say that for the people who may not be the ones only interested in laryngology, yet into head and neck and all, I have been more and more commonly been asked questions on forums regarding to the problems they face with the superior laryngeal nerve resection or accidental damage during thyroidectomies, then actually the recurrent. And I do agree with a lot of these uh, head and neck surgeons where the SLN is sometimes perceived as more of a problem by the patients in the long run than even RLN. And although we always continue to work towards the RL nerve as the treatment modality being the motor one, but here we found that you were addressing in a lot cases reinnovation through the superior laryngeal nerve as well as the superior laryngeal nerve itself. In fact, very recently I've been facing a problem with a massive LTR that I did. I had to release the larynx from almost everywhere, and probably I lost the function of the superior laryngeal nerve at least on one side. And I can see how much difficult it is for the patient to get back into swallowing again, and we are having some tough times. So amazing this thing. I do agree that the lecture was a little bit heavy for people who are not exactly into laryngology. Also, the ones who are into it, though, but very informative as this thing. I think the future is in renovation. There's no doubt about that's the take home message, I think. Very well taken. But yes, for the people who have the patients, they need quick term results. And for example, we might talk about the bilateral cord palaces and tracheostomies patients. They would do well with renovation, but they would definitely, I mean, carbon dioxide, Kashimo's operation, they will still be there to stay, even if we have a better choice in the long run. But hopefully, yes. And if there are any more questions, I'll be happy to give it towards Dr. Chetri. But otherwise, what a fantastic way to wind up. Thank you so much. And I'll hand over the proceedings back to the organizers, please. Thank you so much.
Thank you, Dr. Manish. Thank you so much. I would like to thank both the speakers on behalf of HAOI Haryana. And I'll request our president, Dr. Ravinder Gera, to give his vote of thanks.
Good evening, everybody. I really thank Dr. Sachin Gandhi for giving informative and elaborate speech on the thyroplasty and taking out time from his busy schedule. And now I'd like to thank Dr. Dinesh Chetri for his in-depth insight into the reinnervation, which is the future of laryngology, and taking out precious time from far off. And the last person whom I like to thank is Manish Munjal and my good friend for arranging all this and taking out time for moderating this session. We'd like to thank Dr. Raman for hosting this session. And at the last, we'd like to thank Mr. Yadav, who is the sponsor of this event, NRI Vision Care. So I really thank all the participants who have participated in this program. And once again, thanks everybody. I'd like to say good night to everyone.
Thank you. Thank you, sir.
Thank you very much.